So we're going to be covering some, kind of the very basics of case management today. Um, we know that there's been a fair amount of turnover in the field, and we're working on the assumption that a lot of you are relatively new service coordinators and personal agents, although I'm sure that's not universally true. So these slides are written at a very high level, but we really want you to get out. We really want you to get out of this whatever you need. So there's a lot of you here today, so this might not be the ideal set of circumstances to make this happen, but we're hoping that you can ask questions, that we can talk through some of these things. Our intention is to leave a good amount of time at the end for questions and discussions. We have Nicholas Lervik monitoring the chat for us. So if you want to type in some questions as we go, we can try and address them. We'll pause every few slides to check in on questions. But basically, you can see what we're covering: very basic expectations of case management. We're going to go over some resources, and then we want to talk a little bit about COVID. And thank you everyone really for coming today. I've been at ODDS for almost 15 years now, and before that I was a personal agent. I've been a DSP, group home manager, and throughout my career I can say that what we're doing and dealing with right now is way above and beyond anything I've ever seen. Probably that's true for everybody. So want to be respectful of your time and just acknowledge that this is this is a little weird things going out there. And I know it's been difficult for us at ODDS, and I can only imagine how difficult it is for you to do your jobs under these circumstances. So again, thanks for coming, and hopefully you can get some value out of this presentation. So what is case management? It's a broad term, covers a lot of things. And I'd like to start by acknowledging that not everybody loves the term. One of our first and most active self-advocates, a woman, she passed away a couple years ago, but her name was Judy Cuneo. And she used to like to say, "I'm not a case and I don't need to be managed." And I get that. I appreciate the sentiment. I want to honor it and respect it as much as I can. But I find myself, unfortunately, in the situation of not having a good replacement universal term for that yet. It's all over all of our materials. It's all over federal materials. So I may live to regret this, but I probably will be using the term case management a lot throughout this presentation. This is going to be recorded for posterity, so maybe someday I'll look back on this and be like, what was I thinking? But this is where I am today. So apologies if anybody out there doesn't like to use the term, but just acknowledging that that's there. So case management, it's a service. I mean, it will help you as case managers to do your jobs, and especially to do your documentation. If you remember that what you're doing fundamentally is similar to attendant care or employment path. And you're a service that is authorized in an ISP. It's a service described in a waiver like other services. It implies action, it implies activity. You're delivering something to somebody. So keep that in mind. It always should be in the background of your mind when you're doing what you think is case management. You're providing a service. There's a variety of things that can be case management, and we're going to talk about some of those things, but fundamentally it's you doing something for somebody. So to that second point that you're looking at here, this is the federal definition. Services that assist participants, that's the federal term for what we would call individuals, people, clients, people enrolled in our services. Services that assist participants in gaining access to needed waiver and other state plan services, as well as medical, social, educational, and other services, regardless of the funding source for the service to which access is gained. That is a broad statement. We're about to kind of break down case management into some different sneak preview of the kind of four main categories, if you will. There's assessment, service planning, information referral, and monitoring. We're going to talk about those because it will help you understand sort of what the nature of the job is. But really, case management, as long as it fits into that definition that I just read to you, it's case management. We at ODDS don't care if it's assessment or service planning or information referral or monitoring. As long as it's case management, you've done the service and you can get reimbursed for it, and we're all going to be good. So don't get too caught up in wondering, oh, did I just do an assessment or did I just do monitoring? Doesn't really matter. Maybe your CME cares. I think I've seen some case management progress note systems that ask you to call that out. Your CME may have its own reasons for doing so, but I can tell you from the state perspective and the federal perspective, all we care about is that the service that you provide meets that general definition of case management. And I hope you understand how important the service that you provide is. I mean, for a lot of people, you probably know this, it's the only service they have. They don't need necessarily residential services, attendant care, but they are trying to, the people on your caseloads are trying to navigate a complex system. There's Medicaid, food stamps, VR, HUD housing, the whole array of services out there for the people that might be enrolled in our system. It's complicated, and they need somebody to help them navigate. And you are often that person. So I understand the complexities, and I understand that there's a lot to know to be an effective case manager, but for the benefit of the people on your caseloads, it can't really be overstated how critical your role is. I said case management is a service like attendant care or employment, and that's true, but it operates kind of at a different level, a higher level, because people in our services can't get to any other services without going through you, right? You are the key service to accessing everything else, funded services or not. And in that role, you have, I can't overstate how important your role is to the delivery of developmental disability services in Oregon. You authorize services, but not only that, you have to assure that people are getting the services they need, but in the amounts that are appropriate to them. And that's where the trick is. We, in normal times, outside of COVID, the federal government funds over 2/3 of our services. They pay for, over 67% of everything that we spend. If we get it wrong, if we over allocate resources, provide resources to people who aren't eligible, our federal funding is at risk. And you are the gatekeepers to that. You are the ones making sure that people get what they need in the amounts that they need and are entitled to. And such an important role that you serve in doing that. And so it's important, hopefully you're asking questions, hopefully you have a good understanding, but if not, always be reaching out because it's really important that we get this right. So case management is the service that helps us to continue to provide all of the other services that people need. And case management, finally, is a source of funding for CDDPs and brokerages. I don't know if you know this or not, but every time you go into Express and make a claim for a case management service, the CME you work for gets about $400, somewhere in that neighborhood. So that is the main source of funding for CMEs out there. So it's important just so that you and everybody you work with can get paid. So let's move on. We'll talk about some of the more discrete aspects of delivering case management service.
Do we want to pause and see if, Nicholas, do we have any questions that have come in just about basic case management definitions?
Nothing in the chat yet.
Okay.
Great. Okay, so the first thing we want to talk about is assessment, because these are kind of sequential: assessment, service planning, information referral, and monitoring. Assessment is first. You don't know what services to put it on ISP. You don't know where to refer somebody. And you don't know what you're referring or monitoring without knowing what a person's needs are. If you come away with anything after we leave the slide, I want it to be that the ONA is not the only way to do an assessment. The ONA is a tool that measures people's functional needs. It's a functional needs assessment. There's way more going on in a person's life that you ought to be assessing in order to put together a real ISP that is really person-centered. You can be identifying like family dynamics. Maybe your adult individual's mother, he has low expectations for his ability to get a job, and you might assess that, oh, mom is inhibiting my person's ability to work and live independently. So maybe I want to propose a discovery service for him or something like that. That's not going to show up on an ONA. That mom is maybe not as enthusiastic as she should be, but you're assessing what's preventing this individual on your caseload from being independent in the community. That's one of the fundamental things we want to do. Independence and health and safety are the two basic services that we're really trying to provide. So you're assessing what's getting in the way of health and safety or independence. You can assess that a person's house is kind of always in disarray, and maybe they need housekeeping. That may or may not show up in an ONA. You can assess that a person may not like his job, and there might be a change in, or you might need to change the type of employment services that a person is authorized to receive. So there's a lot more going on than just ONAs or CISs or SNAPs or ANAs, any of that. I mean, any observation that you make that leads to a potential reevaluation or a change in the services that are authorized is an assessment. It's a broad category of things. But any participation in an ONA can still be case management. Any sort of formal person-centered planning that you participate in can be a case management services. Identifying the need for non-developmental disability services. Maybe you walk into somebody's home and you notice, oh, the kitchen cupboards and refrigerators always seem to be empty. So let's talk about SNAP benefits. All of those things. Maybe a person has, you're noticing wounds that don't close, and maybe there's a medical issue that needs to be checked out and they haven't recognized that for themselves. So there's a whole array of things that you should be using your eyes, your ears, all of your perception to link a person to the services that they need to be healthy and safe and to be able to live independently in the community. So assessment is a broad category of things. And hopefully that whenever you're getting information about a person, you should be assessing it for impacts to services. So next slide.
I think this one's mine. So service planning, and just this is beyond the individual support plan or ISP. It's my favorite element of case management, and it's so important for a person, their family, and all of the people that they love and that are in their life. Essentially, this is about case managers being responsible for developing the ISP. But the development of the ISP is not just filling out a form page by page. It's not just one day in the year. It is fluid. It's developed over time, and it may include information gathering that comes from any and all conversations you have with a person and their family and their coworkers and their supporters that you tuck away for future use to develop next year's plan, to modify the current plan based on the things you learn and the things you observe through some of those other case management activities, such as assessment. All planning activities should be centered on the needs, the desires, the preferences of the person. And for children, of course, their families, and for anyone, the other people that they choose to be a part of this process. Service planning as a case management activity also includes collaborating with other service providers and contributing to other plans, developing service agreements and protocols, and participating in, for example, the individualized education program for people you have on your caseload 21 and under that are receiving special education services, folks on your caseload that engage with vocational rehabilitation, collaborating to help develop those plans, help make sure they're aligned with the ISP that you are in charge of developing. And just in case other things come up in those planning conversations that may impact the person's DD services that you are charged with authorizing and overseeing. And broadly, an ISP needs to address independence, integration, and productivity or opportunities to seek employment. This, of course, looks very different person to person. It's never one size fits all. And this doesn't mean that we need to have a goal that says Susie will become more independent or Caitlin will be integrated in her community. So it can really look a variety of ways, and broadly, the plan should be ensuring that those things are happening. Planning includes supporting a person to identify their goals, short-term and long-term, the supports and services they need to make progress toward those goals, choice advising around their case management provider, service providers, and settings, risk management planning, backup planning. And yeah, that's essentially the planning components of case management. It's beyond that one day in time where you're sitting together and maybe completing the ISP. It's informed by all kinds of conversations that you might have throughout the year, and it involves that collaboration with other service providers like special education, folk rehab, behavioral health, etc. Oops. Oops. Hey. Okay, touchy mouse here.
All right, so the third broad category of case management we refer to as information and referral. Like I said before, the environment that our services exist in is complex. It's beyond just developmental disability services. And the people who are on your caseload probably don't necessarily know what's out there. So it's up to you to identify those resources that are out there. And I'm speaking of like VR, mental health, the health plan, legal aid, public health, welfare benefits. I mean, all of that stuff, and DD services. You're one of your roles is to know those resources and being able to connect somebody with those resources, because they may not know they exist. They may not know the phone numbers, the names of the people to talk to, the words to say. Every system is a little bit different in their terminology. And, the more experience you gain as a case manager, the more familiar you're going to be with those, and the more effective you're going to be able to be providing information and referral services. But, just recognizing that there's a whole array of services out there for people, and they may not know what they are. And they're going to be counting on you to be able to hook them up with those services. So that's broadly information and referral to the big system. But choice advising also counts as information and referral. The thing about choice advising I really would like to emphasize is that it's not a one and done. There are points in time where choice advising is required to be done, but choice advising should be a continuous process. You should always be thinking about choice advising. Part of your case management duties and responsibilities are assessment and monitoring. So we'll talk about monitoring in a bit, but if you notice that somebody's provider may be underperforming, or there's a conflict between the individual and the provider, that's an opportunity to offer choice of new providers or new services that might make more sense for this person. You should always be evaluating the person's place within their ISP, how their services are being delivered. And if something's not right, talk about options. It should be continuous and ongoing. There should always be discussions about choice. So while there are those particular points in time, like around the ISP renewal, you should be doing definitely choice advising. It should be a nonstop activity. Information referral occurs a lot when people move. We know people in our services move a lot around quite a bit, especially those in in-home programs. All of the work that you do to make a transition happen smoothly by giving information to the receiving CMEs, by giving information to new providers so that they can deliver services, is all part of information and referral. I should mention that not all information and referral services have to be to the individual. You can give information about other services to family members, to providers, to anybody who might be there helping the person on your caseload get the services that they need. It's true of all case management services. They don't have to be delivered specifically to the person named on the ISP. It can be for contact with anybody who is facilitating access to services. Anything that you're doing with respect to any of these case management activities we're talking about that facilitates health and safety and access to the broader community is going to be case management. So don't get too hung up on who your service involves. It's always going to be about the individual, but it doesn't have to be directly with the individual. And then kind of the last thing is the ongoing access. Your abilities and work towards making sure that people stay eligible for Medicaid, because we know that's really important for a lot of people to have access to not just our services, but their healthcare. And you're also helping us with information and referral to fulfill our federal requirements that people are informed of choice, and that their rights are assured. All of these things are could be lumped under the category of information and referral. So next up.
So case management monitoring. This includes, of course, the quarterly or monthly monitoring that's indicated on a person's ISP to inquire about the quality of their supports, progress toward goals, and any changes that need attention. Monitoring must happen at least as often as indicated in the ISP, but it really can and should happen as needed, and that changes over time. Any conversation with a person is an opportunity to monitor. It's an opportunity to dig in and ask more questions and really try to find out how supports are working for a person, whether the person needs new or different supports or something else has changed in their life that might indicate an opportunity to change their plan or to perform choice advising like Mike just mentioned, or provide additional resources. So monitoring includes that direct monitoring where you're checking in with that person or their designated representative to inquire about quality and satisfaction and changing needs. But it's also indirect monitoring, which is when you're reviewing documentation that is sufficient to draw conclusions. So it's not just reading paperwork, but really reading something that can give you enough information that you can assess as a professional whether something in the person's plan is working or not working, whether a provider is providing the supports as indicated in the ISP or not. So reading a detailed progress note and drawing a conclusion about how supports are working can count as monitoring in that indirect monitoring. And when incident reports come in, reading an incident report, drawing conclusions based on that report, and then following up as indicated also counts as monitoring. And really, truly, any and all opportunities to see a person or to see others that are on the planning team, others that are important to this person and involved in their services is an opportunity to monitor.
And I do have a question coming in the chat. The question is back to information and referral. Is it considered a billable activity to send a transfer packet to a new CME prior to a transfer? I always thought of this as a clerical task.
Sure.
Great question.
Yeah. Putting materials in an envelope is a clerical task. Gathering the materials that need to be in the packet is a case management task. You have as a case manager, the specialized knowledge that the receiving CME and providers are going to need in order to deliver services. Again, to keep people healthy and safe and to access the community, live independently. So the judgment that you use to determine what gets included in the packet is case management. But getting it out the door, you're right, that's an administrative clerical task.
And I think some of whether that's a case management activity or not might depend on how it's documented, right? I mean, and then we'll talk about that in a minute. So what are you describing in your progress note about what you did? If it's, I sent a packet, then maybe not. But if it includes information on what you did to gather the information specific to the individual so that their needs could be met, then maybe it is.
Okay, this is me again. Yeah, case management can happen through a variety of mediums. It doesn't have to be always face-to-face with somebody or the individual in particular. It can be with, like I was saying, other people, but phone, written documentation that goes back and forth, emails. We're working on policy around texts. We don't have that yet, but during the pandemic, I know the text gets used a lot, and that's fine. But yeah, just don't get hung up on the medium too much. Get hung up on privacy, but don't get hung up on the medium. There's lots of ways that you can deliver services that keep people healthy and safe and that allow them to live independently in the community. Always, it's going to go back to that. Like I said, case management doesn't have to involve the individual who's named on the ISP. It can be a family member, a friend, a neighbor, the employment provider, the residential provider, the person at the Social Security office. as long as you're meeting that overarching goal of getting people to access services, whoever you do that service with, it can still count as case management. Some case management services take more than one contact, like arranging, getting everybody together on the same page for implementing an ISP. It may take several conversations, phone calls with several different people. The task, though, is the case management service. So when it comes to billable, you have to sort of think, even if it takes several different things, if it's all working towards the same case management service end goal, only once the service has been completely delivered, everybody who needs to know has been contacted, at that point, it becomes a case management service. But you just have to recognize that sometimes it takes time and multiple steps to get to the actual completion of the case management service. And only the service as a whole is billable. The individual steps leading up to it aren't necessarily. Monitoring doesn't have to be, and other case management services don't have to be only about paid supports. You can monitor natural supports, and if they're not working out for the person, maybe have a discussion with them about, how might their needs get met. And of course, also other, the Social Security office, the Medicaid, housing, VR, all of that other stuff. They're not paid by us, but if you're helping the person to access those services or to access and understand them, then it can still be case management. And lastly, even though most of the people on your caseload are probably Medicaid eligible, they don't have to be to get case management. I think people don't always realize that. Everybody in Oregon who's enrolled in DD services has the right to get case management services. And your CME also gets reimbursed for them, whether they're on Medicaid or not. Maybe this is something you don't care about, but I said each billable contact is worth about $400, and that's true until you hit a monthly cap. So what we do behind the scenes is prioritize the billings for people who are Medicaid eligible. But if your CME doesn't have enough contacts with people who are Medicaid eligible to make their monthly limit, we will reimburse the non-Medicaid case management activities.
And we do have another question coming in the chat. The question is there a time frame for knowing when the policy regarding cell phone contact might be finalized / communicated to CMEs?
Hopefully prior to the end of the pandemic.
Yes, thank
We
you,
are
Nicholas. We are working on it. And the public health emergency just keeps going, doesn't it? We keep anticipating that maybe the end is near, but right now that doesn't seem to be the case. This is just really a quick slide and reminder that even activities that you perform that are not case management activities, that are not billable case management activities, doesn't mean they're not important. So not billable does not mean unimportant. It's really important to document everything of relevance about a person that you learn and all of the activities that you're doing to support them, whether they're case management activities or not. While nearly every contact is an opportunity to deliver a case management service, such as monitoring, sometimes it doesn't happen or it really isn't needed, and you're doing something else that is still important, that still we want to see, and for continuity of care is really valuable to have in that person's written record.
Yeah, I think it's important to remember that, especially the progress notes, that's the source of history for the people on your caseload. You may or may not be their assigned case manager for years and years. Again, and people move, case management entities change, but the people who will be coming after you are going to need to know more, most likely, than just the case management services that you delivered. They're going to need to know some context sometimes. And so even though it may not be a billable case note, it's still important to preserve that history. All right, so things that you may end up doing that don't count as case management. And I should emphasize right off the bat, this doesn't mean you shouldn't do them. Some of these things are really important, and the billable rate that I talked about later accounts for some of these things. The billable is supposed to be enough to cover that service plus some of these other things that aren't necessarily billable. So things that are not case management, sometimes direct services. For example, sometimes you may, find yourself in a position where you have to drive someone to a doctor's appointment or something, or help somebody fill out some paperwork. These are direct services. Think of direct services as things that you probably could authorize in an ISP, but didn't for whatever reason. If you're providing transportation, there could be a transportation provider authorized, but maybe this is a one-time deal, couldn't find a provider, and you end up doing it yourself. Direct service may be very fundamentally important to the person, but it's not case management. Of course, if you're driving somebody to the car and you have some time to talk, that's a perfect time to do assessments, monitoring, and all those other things. So just make sure that whatever you're documenting reflects those activities and not just that you drove somebody to the doctor. Duplicated services, I don't think this comes up for us very often. The main one I could think of maybe is if you accidentally claim to have completed an ONA when an assessor completes an ONA, that would be considered duplicate service. But I think we have lines drawn pretty clearly between the assessor's role and the case manager's role. But if you have questions about that, let us know. But yeah, just make sure that you're not doing exactly the same thing that someone else in your office or another office who might be claiming case management. I guess that's a important point to make too, that I guess there are possibilities for kids in CIS or kids res who have a CIS service coordinator or a kids res coordinator. They're making claims for case management services as well. So just make sure you're clear on who is going in and billing for that service. You can't pay both of you at the same time for the same service.
We have another question in the chat real quick. Is attending an IEP a duplicate service?
Well, attending an ISP isn't necessarily a case management service in and of itself. You can do case management activities at the IEP if you're relating the developmental disability services to the school services, making sure that you're, kind of on the same page, so to speak. Like maybe your behavior interventions line up, that the services that the kid is getting at home are complementary to, but not overlapping the school services. Those are all case management tasks. And if you're doing that, it's not duplication of services. You're coming at it from the DD perspective. The teacher is coming at it from the school's perspective. You have different roles. You have different outcomes. You're writing different plans. So no, there's not really a worry of duplication there. The worry is that you don't document your case management activities at the IEP. And we'll get to documentation in a few minutes.
Thanks, Mike. We have just one more question in the chat. If an assessor completes an ONA, but I am completing an ANA at the same time, does that then become billable for me also?
Yeah, they're different tools. They ask slightly different questions. You're probably using the information slightly differently. And again, you're using your professional judgment to complete that tool. So since you're doing that, it's a case management activity. Yeah, no conflict there.
Are there other questions?
That's it for now.
Okay.
All right. And so, yeah, it's also not case management, just doing the busy work of going into Express and, writing out a plan of care or authorizing CPAs, things like that. And other administrative tasks, filling out forms, like we said, stuffing envelopes, writing progress notes, completing incident reports, all of that stuff. It's kind of the behind the scenes work that gets done, captured in other billables, but not separately billable. And then general outreach. If there happens to be like a job fair for people who experience autism, and you mail out the flyers to everybody who may have that diagnosis, that's not a separately billable activity. It's not tailored. It's just could be considered another administrative task. But these are good questions. These are the ones that get challenging to discern what is case management and what isn't. So any other questions around this are welcome, and keep them coming even as the rest of this presentation goes on.
Yes, thank you. So why does documentation matter? Why do progress notes matter? Really, a progress note for a billable encounter, or for any encounter, honestly, is not just about the individual. We really want to know about what you did as a case manager, as a services coordinator, a personal agent, what you did for the person. And the progress notes that you write are how you demonstrate that you're performing those 4 essential functions of case management: assessment, planning, information and referral, and monitoring, as well as other important services that you provide, and Mike talked about just a couple slides ago. Additionally, progress notes can provide a lot of information about what's happening in a person's life, context that's important to track, family dynamics and team dynamics that someone else that's maybe subbing in for you when you're out or on vacation, maybe things that they would need to know. It's a record of action items, of information that may contribute to future assessment or future planning conversations. You may note that someone really enjoyed an activity. A designated representative mentioned the possibility of moving in the next couple of months, or a person is starting to get fed up with one of their providers. Those little nuggets of information that might be added to a progress note, that's good stuff to come back to later and follow up in with other case management activities. So good, up-to-date progress notes ensure that continuity of care. You're out, you're in quarantine, you're on vacation, you move on to another position, and someone else needs to step in while you're away. It helps make sure that balls that are in the air aren't dropped, and that a person's needs, most importantly, and required system deadlines, secondly, are met timely. Any questions, Nicholas, on documentation? We are going to talk a little bit more about what documentation looks like and some tips and tools for making sure your progress notes meet requirements.
I would like to add, just don't make assumptions about the reader. Don't assume that they know what you're doing or what activities go into the services that you're describing. It's, pull back the curtain a little bit, you probably don't know this, but when the QA field review team goes out to your CME for the QA review, they look in Express, find dates that you made billable claims, and then go look at the case note to see if it represents a billable service. And they give a report back to the CME, and the CME has an opportunity to challenge those findings. And when those billables that are challenged come back to us for review, it comes to Caitlin and I and one other person in our office. And Caitlin and I have done case management. So it's hard for us. Sometimes we'll read a case note and we know what you did, but it doesn't say it on the page. And it's really frustrating because we really want to be able to give you guys all the credit that you deserve. But frankly, it's not just us. Secretary of State's audits happen, CMS audits us, and they probably haven't been case managers. So it's really important to fully explain what it is that you did, and don't make assumptions that the reader knows what's going into it, even if it seems obvious. Write the obvious, write it to an audience who is ignorant of your job.
Yes, and at the same time, don't get hung up on discerning whether it was monitoring or planning or assessment. Call it what you want to call it, but tell us what you did. That's the most important thing. Nicholas, are there questions in the chat?
Not at this time.
All right, where are we? So yeah, I guess I just kind of made that first point. Yeah, be specific. Describe the service as best you can. And the rest is kind of technical. Just make sure that the name of the person is somewhere in the progress notes. It can be at a header if it needs to be. Put names and roles of people. I can't tell you how many times we are reviewing contested progress notes and it just has a first name. Like, I don't know who that is. We need to know why they're there, what their role is, why you are talking to the person, how that discussion relates to the ISP or health and safety or independence. Again, I get progress notes are sometimes the last thing you want to do, but they're really, really important for our ability to maintain our relationship with CMS. That's how we do it. So please make sure that there's enough detail there to describe the service and how it ties back to identified support need or the ISP, something like that. And then make sure that it's clear that you are the one who's written the progress note, because you are the qualified person. You meet the qualifications we've described in our waiver. And if you are not qualified to deliver case management, we are not able to reimburse your CME. So make sure that it's clear that you are the one writing the progress note.
So other basic things that progress notes must have, and the month, the day, the year that services were provided, and the date that the entry was written, if they're different, and often they are. We know that you're not always able to write progress notes on the same day. And that often systems auto-populate this kind of information, but not all do. Every CME uses something a little bit different. So if that's not something that auto generates, then make sure that that information is there. And there's lots of other important information that you might include in a progress note. What was the format of the meeting? Was it in person? Was it over the phone? Was it over Zoom? Was there an interpreter present? Was someone invited that is really important, but they didn't attend? And you might want to note that for future planning or future follow-up activities. And always be consistent with your agency's policies and procedures, as some CMEs, like Mike said, might want you to select what kind of case management activity it was, or might have other information that they're collecting for their own purposes. So always being consistent with whatever your agency or organization requires, but making sure to have that basic minimum information and other details that are important.
All right, some good practices. That first bullet point, I think I was kind of talking about that before, but like, why are you writing this progress note? Why did you do the thing that you did? On my PowerPoint here in front of me, I forgot to forward to Caitlin, but I highlighted the because in yellow, because it's so often, again, when we're reviewing contested progress notes, it's like, I did a thing for somebody, but why? Is it because it's in the ISP? Is it because they had a medical emergency? Is it because you assessed something new about the person? The why is so important. And if it can't tie back to somebody's assessed needs or challenging circumstances, then we can't call it a case management service, because all services, case management included, have to be based on a need, right? So if the need isn't described in the case note, it appears to be, it's unclear or impossible to verify that it was needed. So just remember the why. I did a thing because. If you can do that for every case management billable service you're describing, you'll always get the claim. You get in the habit of using the active voice. To remind people that a case note, especially a billable one, is not about the individual. It's about you. It's about what you did for the individual. So, the classic passive voice, mistakes were made, rather than I made mistakes. I don't want that to be your case note, but that's the point. Like, I did this thing. I'm the case manager. I did this, this, and this. Not, a thing happened, but you're not attributing it to you doing the thing, then it doesn't look like it's a case management service. So it's just a writing habit to get into, using the active voice. Progress notes, remember, they're a legal document. They can be subpoenaed. When you're talking with the people on your caseload and families, be casual. You can use whatever sort of language you need to, whatever terminology you need to, so that you can have a good relationship and be understood. But a case note is more formal than that. It's just be cautious in the terms you use. Keep opinions about people sort of to a minimum, unless it's about an assessment sort of thing. But can't overstate how important it is to maintain professional language in case notes, because you never know where they show up. Yeah.
Well, I made that little mark on the screen and it apparently showed up everywhere. Here, let's see. Okay, it's gone. Yay. So some tips for progress noting. I've never done that before. I was trying to highlight your because this DAP is an easy to remember acronym. You may have heard of it and maybe something that your agency or organization trains already, but if not, or if you need a refresher, DAP is description, assessment, and plan. And it's just a good acronym for making sure your notes have everything needed. So that D, description, where were you? Who is there? What was the purpose of the meeting? And what occurred? Ensure that you're mindful about what you think versus what you know. Avoid judgment, bias, assumptions about a person's feelings or a person's motivations. Document what is observable, what happened. Describe the meeting, the encounter, with all of the details I just mentioned, that who, what, where, when, why. Assessment or analysis. Out of those things that you described, the things that you could observe and that encounter that you experienced, what does that actually mean? What professional conclusions did you draw? You are a professional and expected in those, and when you are encountering a person, when you are providing case management, that you're using your best judgment and determining a course of action. So what case management service did you provide, or what did you do based on the information that was described? And then finally, that third component, what's next? What's the plan? Is there any follow-up needed? Are there adjustments needed to the person's ISP? Do you need to connect with another team member and catch them up? Is there a referral that you need to send? State your plan. Clearly in the progress note, I will do this in this many days to state exactly what the plan is moving forward. And then we would expect to see a subsequent progress note, however, later, that shows that happening. So that follow-up is occurring and the loop has then been closed. Do we have questions about DAP? Not DAB. That's what my 9-year-old does.
We just have a question wondering if these slides will be available to download, and if so, where?
Yes, so after the session, I will email out these slides in a PDF along with a survey. And so you'll have the opportunity to look at them. And then all of the sessions from the learning series are being recorded and then placed on our, I think, provider partner resources page on our website. And I can send that link when it's available. This one probably won't be posted until sometime in October.
Thank you. We have another question. Is there a time frame to have PN completed for ISP, change form, GERs, and IR?
We don't set a time frame. The sooner the better, obviously, because fresh information is much more likely to be accurate. You know, memories are fallible, so the sooner you can write a progress note after an event happens, the better, of course. That said, your CME may have its own policies. I know many of them do about timeliness of progress notes. But at a certain point, it becomes more of a HR issue for the CME than a compliance issue with us.
Thanks. That's all the questions for now.
Okay, so just wanted to run through, you may know all of these already, but just in case, I wanted to show you some of the tools that we have available for you as case managers. Okay, let me click on the second one. I think that's the most useful. If I was still a case man, was that working?
Yeah, so what I'm going to do is stop my screen share and then go to my web browser where I have all these ready to go because it was being funky earlier. So just a moment. Okay. You should be able to see my screen again and see that page. Okay.
I think if I was still doing case management, I think I would have this as my home page, because from here you can get to just about everything else that you're going to want to know. At the very top, there are the tools and resources for CMEs. So you can see there's links to the administrative rules. There's links to our transmittals, that brokerage personal agent tools and case management tools. That's the staff tools pages, Compass resources, training materials, and everything that you might want to actually link to on our site is here. So it's my suggestion. And I think maybe, what should we do next? Caitlin, would you click on the ODDS transmittals? That third bullet down there. There you go. So,
There we go.
yeah. So a couple things about this page. At the very top, where it says subscribe. If you're not subscribed to this page, I would suggest that you do so. That way you'll be notified anytime there's a new transmittal that comes out. So you can, it'll be in your inbox as soon as it's released, and you can review it and, you know, start discussing with your coworkers what it might mean. Some of them aren't relevant, of course, but better to have them and you can just dismiss them than not. So please do sign up. And there's a similar subscription option on the engagements and innovation page. I don't know if you've been to that page or not, but I'm not sure I'd call it a tool for case manager, except that it gives you insight into what we're thinking and what might be coming down the pike, and gives you an opportunity to provide feedback. So this is where we post our proposed transmittals or workers' guides or policies or whatever we're thinking about issuing. So as a case manager, you'll be able to see what's coming up and have an opportunity to give feedback directly to us. So sign up for that as well, and you'll know when we're posting those things. Yeah, that's what that looks like. But if you go back, I wanted to talk a little bit more and scroll down just a little bit. So yeah, the search function there. When you type a term into the search function, what it's searching is under the column title and summary. It's looking for those words. Unfortunately, our search function does not go into the transmittal itself to review the text. It only is searching the page that we're looking at right now. So we're trying to get good at anticipating the words you might need to type in to find what you're looking for. So we're trying to do a good job of that. One of the things about the Engagements and Innovation page, though, what we always ask is, if you find yourself needing to look for this transmittal, what's a useful search term? So we want the summary to have all of the useful search terms in there for you. So that's another good reason to go to the Engagements and Innovation page, and you can tell us, if I was looking for this, I'd want to see PSW show up, or I would want to see employment show up. Whatever it is you think might be useful for you to find the transmittal based on the information that we can provide you on this page. There's a similar page to this for workers' guides. You know, I've stopped using staff tools for workers' guides because it's completely disorganized and really hard to navigate. But here, same, it's got a search function. I find it much more useful than the staff tools page for finding workers' guides. So, you know, this is another useful thing for you. I think that's pretty much all I really wanted to point out. And then just kind of in the background, and so you know, the case management services we've been describing are, of course, regulated by a rule, and it is Chapter 411, Division 415. In your spare time, if you're not already familiar with it, I enjoy reading rules, maybe you do too. But yeah, you can be familiar with this. It's what we tell CMS we're going to do. It's what our QA unit does their reviews against. So it's an important document. It's not necessarily important for your day-to-day case management activities, and I know you'd rather be focused on people on your caseload, but you know, it's an important set of rules, and the more familiar you are with them, I think it's probably the better you're going to be ultimately at your job. So that said. So any questions about what we've covered so far? I think next we're going to shift into COVID, and there will be, I'm looking at the time, I think we're going to have plenty of time at the end for questions, but anything?
No. Oh, I think one just came in. Also, thoughts on Sorry, guys. I am having mouse troubles today like you wouldn't believe.
Maybe I can find it.
Can you provide some examples of acceptable case notes and ones that are not acceptable?
I think that I haven't reviewed these for a long time. Anybody who's been through the case management training orientation recently, doesn't our staff have some of those? Would have been, I think, Christine Duffy, and I can't remember who else does those trainings. I thought they had examples that they go through.
They do, and we might be able to find like a PDF version that we can email out to you. And then I think there are also examples in the core comps trainings.
Okay, Brent's saying, yeah, they exist. We haven't done the training for a while,
Yes.
which maybe that's a good lead into COVID because that's
Okay, thank you. That's
Thank you.
oh, we have a comment at my CME training. They refused to provide us with appropriate examples. They only provided us with examples that were not up to snuff.
We will try to find something and follow up in the email that goes out with this PowerPoint. We can try and find some good examples for you. So COVID-19 and case management. So as you know by now for sure, and the work that you have been doing over these past 18 months, people with intellectual and developmental disabilities are disproportionately impacted by COVID-19. So they are more likely to experience severe disease, poor outcomes, and death. And people with intellectual and developmental disabilities, of course, intersect with people of color, Black communities, Alaska Native and American Indian communities, Asian American and Pacific Islander communities, particularly, and of all races, people that identify as Hispanic or Latino and Latinx that are also disproportionately affected by COVID-19 and experience those higher rates of infection, poor outcomes, and death. Our most important, most fundamental, basic responsibility is the health and safety of the people with intellectual and developmental disabilities that use our service system. And the roller coaster, that's how it's felt for us. So we can only imagine it's like a roller coaster going 100 times faster than what it's been like for us, for you. But the changes and flexibilities that we've thrown out at you and your ability to stretch, flex, respond as a result, all of that is intended to keep people safe and balance those challenges of exposure to other people, risk of transmission, and then risks that are associated with social isolation and individual rights and preferences. Really, the most important thing for right now is that most services that you provide are happening virtually, as they have been for the majority of this past 18 months. In a typical day's work in the before times, you might go into multiple homes, you might go into multiple state offices, you might run around and run errands in between meetings, and then also be in your case management entity office, interacting with lots of different people throughout the day. Mitigating the risk of outside folks coming into the homes of people with IDD is an essential part of protecting people's health and safety right now. So that's why in-person case management is currently paused, with one exception, and that is, of course, going back to health and safety. For people who are at risk of abuse, you have any reason to believe that they're at risk of abuse, there's a history of abuse, there's a history of safety concerns related to social isolation, someone that you normally have an easy time getting a hold of, but maybe you're not able to get a hold of them right now, some weird text message that you received, a concern that someone else reported about a person, following up on a previous issue or incident. Those are the times when right now, even though case management is happening virtually and even though in-person contact is paused, those are the types of situations where it is okay and it is important to see people in person. Of course, there are protective personal equipment requirements screening requirements for yourself for symptoms, and ensuring, of course, that you are not currently in quarantine, you are not currently in isolation, you are not currently infected with COVID-19. But if you are well and those concerns are happening, then you should be going into a home and seeing a person right now, even though other case management activities are happening virtually. And all the requirements around screening and PPE is in the case management entity reopening guide. And when this current wave of Delta slows, then we will be releasing updated, refined guidance on resuming in-person contact with a little bit more clarification, a little bit more information than when we kind of went back to in-person contact, annual contact back, I think, on June 30th or so. Questions on that right now? We are going to talk a little bit more about other COVID policies.
There is a question in the chat that I missed. The question is, can you review limitations or requirements around case management tasks required for billing, such as time limits, billing amount limits, etc.?
Can you repeat that, Nicholas?
Yes, the question is, can you review limitations or requirements around case management tasks required for billing, such as time limits, billing amount limits, etc.?
I guess I'm not sure I understand what the ask is. In order for a case management service to be billed, there has to be the supporting case note describing the service, has to meet the definition of a case management service. There has to be a claim in express. It has to be within, the claim has to be within a year of the service. Trying to think if there's anything else that might be relevant to know. Does that answer the question? Or?
If this person wants to raise their hand, they can unmute and give us more information.
They said yes, that did answer the question. Thank you.
Okay.
Good. All right, great.
Okay. Well, I think I said the pandemic has been weird. I have seen changes that I never thought I would see happen in my lifetime. So yeah, pandemics are interesting, aren't they? Some things that are very different than the way things were before. Signatures are not required on any of our OGDS documents, quote unquote, new term for me, wet signatures. Never heard that before the pandemic. Wet signatures not required on just about anything that we require signatures on. I want to make that distinction. There's still probably things that require signatures that are outside of our control. I think most commonly that you're going to run across are PSW timesheets. That's a PPL and their business, they require the signatures. It's outside of our control. But ISPs, rights documents, for the time being, freedom of choice, and any of the things that we require you to have signatures on, verbal approval is okay, just in order to minimize contact. Signatures are better. Like if you could do it through the mail, that's ideal, but not required. In-home hour exceptions are not required to be resubmitted. Any exception that has previously existed can continue for the time being indefinitely. As to most of these changes, you can expect to run at least through the end of the public health emergency. The feds have told us that they intend to give at least 60 days notice before the end of the emergency. So that should give us time that to unwind these policies, to give you the information you need to unwind them. I seem to remember that there's also a time period after the public health emergency that we can unwind these. So we should have plenty of time to communicate out what our expectations are going to be and to give you time to hopefully someday get back to normal. Maintenance of effort. Because CMS has given us a bunch of extra money now, in return, we have to make sure that people don't lose their health coverage. So for people who become ineligible for DD services or who don't show up for the ISP meeting or their ONA or whatever, we can end developmental disability services because that doesn't affect their access to Medicaid. unless they qualify under the 300% group or through PMDDT. And I don't know if I should go into explain what those things are now or not, but briefly, the 300% group, in order to qualify for Medicaid, you have to have, there are income limits. You can't make over a certain amount unless you're getting waiver services. Then you can have up to 300% of that amount. So people who earn between the federal poverty limit and 3 times the federal poverty limit can continue to access Medicaid if they're getting waiver services. That's why those folks, we can't end their case management or employment services, because those are waiver services, and that's what keeps them having access to their health care. But other folks who are, what we call drawing a blank, who qualify under regular financial requirements, we can end services for those folks. And again, that you should be, someone at your CME should be keeping track of those people who we have not exited because of that reason, because when the pandemic is over, we will have additional steps to take with them to end their services appropriately. We added a new category for PSW overtime that has to do with COVID. If individuals can't have enough PSWs because there's just the workforce isn't there due to COVID, we can approve overtime. Also, if people, I think, I shouldn't speak unless I'm looking at the opening guide, but the reopening guide has all of this stuff in more detail about it. Just wanted to call your attention to some of the highlights. Remote assessments, again, we're not doing in-person face-to-face contacts for ONAs for the time being. That should be all done virtually. And then there's the paid supports for a parent of a minor child. So any child whose CNA or an exception gives them at least 240 hours per month, that parent can be paid as a PSW or as a DSP to provide supports to their child. Hopefully, if you have children or parents who are taking advantage of this, please don't give the impression that this is going to be permanent. This is going to end at the end of the public health emergency, and they're going to need to be prepared for that.
We do have a few questions in the chat. I think this most recent one you just answered, when excuse me. When will that end for parents as PSWs? It sounds like the answer is at the end of the public health emergency.
Yeah, like I said, I'm not off the top of my head. I don't remember exactly what the feds have said about timelines, but yeah, at least through the end of the public health emergency.
Thank you. Another question, just confirming that you included freedom of choice in the list of documents that do not require a physical signature at this time.
At this time, yeah. Eventually, those are going to need a physical signature when we go back to in-person.
Thank you. Verbal approval still requires it to be documented in a progress note, correct?
Oh, yes, absolutely.
Okay. The verbal agreements, the verbal agreements, should those be noted on the document or just assumed that they were gotten?
I can't remember if we were specific. I think at least a progress note. I think, I don't remember. I'm sorry.
I think at least a progress note. Go into the reopening guide to get more information.
Yeah,
for sure.
Another question, some of these COVID temp changes were lifted for a brief period, but then put back into place. Do you have the dates of these? We disenrolled 3 people due to no contact a few months ago.
Say that again.
Some of the COVID temp changes were lifted for a brief period, then put back into place. Do you have the dates of these? I think when they were put back into place. We disenrolled 3 people due to no contact a few months ago.
Yeah, so I remember we got notice that that it was okay to disenroll people, and it was just for, gosh, I can't even remember how long, but I just want to make sure that I'm getting the dates right. There was, I'm sorry. But yeah, we got notice that, okay, the 300% thing was gone. And so we got a bunch of notices for people who had Medicaid issues. And then there were a couple people that we didn't hear from for a year. And so we wound up disenrolling them.
I think you might
Um,
want to email us.
That's what I
Okay.
was gonna suggest, yeah.
We have another question regarding exceptions not requiring annual review. Does that apply to any and all current exceptions?
In-home hour exceptions, yes. Provider rate exceptions, no. Those require renewal and review at this point.
Thank you. Another question, can all overtime be approved at the CME?
It can, as long as it's consistent with the worker guide and the reopening guide. So not all overtime, but if the overtime is consistent with the existing workers guide, which does not include COVID stuff. So you have to look at two places, the existing PSW overtime worker guide and then the reopening guide. So those two documents will outline under the circumstances which a CME can approve PSW overtime.
Thank you. You may have just answered this question, but it's related. How do we get the overtime approved for a PSW or parent having overtime due to COVID?
Again, it would be consistent with the reopening guide.
Okay, thank you. That's all the questions at this time.
All right, thank you. So I think this is our last slide before we go into setting aside just a little bit more time for questions. We wanted to mention the action request transmittal that was released just on Friday, I believe, that does describe both Executive Order 2129 that requires COVID-19 vaccination for executive branch employees and workers, and the Oregon Administrative Rule 333-019-1010, which is an Oregon Health Authority rule that requires vaccines for healthcare staff in healthcare settings. So read that action request. It's quite long and complicated, but it have a lot of critical information. And essentially, this is about the COVID-19 vaccine requirement. On or before October 18th, people need to be fully vaccinated if, as part of their job, they do business at state work sites. And state work sites, this is the executive order, state work sites include places like stabilization and crisis unit homes, CIIS offices, child welfare offices, APD offices, those AAA offices, self-sufficiency. All of those places are considered state work sites, and people who do business as part of their job in those state work sites need to be vaccinated on or before October 18th, according to this executive order. And then the Oregon Health Authority rule is really about people who do their job inside residential settings. So it defines healthcare settings broadly. Included in that definition are 24-hour group homes, as well as our adult foster homes. So SCs and even some PAs who go into those places as part of their job would be included under that Oregon Health Authority rule. Brokerage staff may be impacted when, for example, they go into a 24-hour residential home or an adult foster home to provide crisis care coordination, or for someone who's leaving in-home services to go and be placed in a 24-hour home or adult foster care setting, or someone who is moving from one of those settings into an in-home setting, and a brokerage staff spends time as part of their job in those residential settings, they would be included. So a number of people are included in both the executive order and the healthcare rule. And then there are also staff at case management entities that may be just included in the executive order. We know that this has a big impact on case management entities and providers, and it's a huge workload potentially for lost capacity. And we're moving quickly and working hard at ODDS to try and offer more flexibility to support case management entities during this time, with the anticipation of potential loss of staff. And there are lots of resources in that action request transmittal that's linked here that you'll be able to access when we send out these slides. That includes some visual aids for which vaccine you would need to take, or as another CMA would need to get in order to be fully vaccinated by that October 18th deadline. Some frequently asked questions about who it applies to, what enforcement looks like, as well as some flow charts that are helpful to just, if you're just not sure based on your specific role at a case management entity, if it applies to you, we have grids and flow charts that can help answer those questions.
And we do have a few questions in the chat. Mike, could you repeat the answer you gave regarding the question on exceptions not requiring annual review? Does that apply to any and all current exceptions?
In-home hour exceptions, provider rate exceptions, employment exceptions, all of those do require annual review still.
Thank you. Next question, will the third booster shot be required when it is available?
This time, that is not mentioned in any of these in the executive order or the healthcare rule.
Thank you. Where do persons who are AFH providers submit religious exceptions, oh my goodness, I cannot talk today, exception or medical exception requests? Is this to the local CDP?
That information is in the action request and in the FAQs, and I can't remember off the top of my head, so I would refer folks back to those documents for answers.
Thank you very much. That is all the questions for now.
Okay, and I think that's our last slide. So we have about 10 minutes left with you to answer other questions, and you can feel free to type in the chat as you have been, or raise your hand if you want to ask your question and unmute yourself. That is fine too. And I think I'm going to stop screen sharing so that I can see some more of your faces. If you have your cameras on, which now it just looks like, hey, Mike, good to see you.
And our contact information is there. So, like I said, we understand and appreciate your job is really complex. So, we're here as a resource. I mean, we get paid to do that, to answer your questions. So even if you don't have them right now, if they occur to you later, reach out, let us know. We want you to get it right because it's important to us. It's important to the people that you serve. It's important to our system as a whole that we get it right. Like I said, you're the key to the whole deal here. So, we want you to be successful, and we're happy to help out as much as we can.
We will sit in awkward silence for 10 minutes if that's what it takes.
Third person, first person case notes, that's a matter of style. Yeah, we don't really care. Again, as long as the case note is describing the service that you provide, you can use a pronoun, you can use your title. Doesn't really matter to us, whatever you're comfortable with. I can tell you reading them, I prefer first person, but that's just a personal preference of mine.
It looks like there's questions on exemptions, and I would really direct you to that action request and the frequently asked questions for any questions about the vaccine mandate, whether it's the executive order or the healthcare rule. And there's a contact at the end of the transmittal where it says contact. I think it's the ODDS COVID-19 team. If you contact them, then that's just really important because we might be getting the same questions from different folks all over the place, and we really want to gather them all into one place and make sure that we have consistent answers for you if it's something that's not already addressed in the documents.
I think we'd like to acknowledge too, before we go, that we know the impact that this vaccine mandate is going to have on provider capacity, and it is not small. So we are doing what we can to identify strategies that will make the impact less dramatic. So keep your eyes open. We'll be issuing communication about that soon. Love to hear any ideas that you might have to help with that. But this is unprecedented, and unfortunately, well, it's out of our control. And we have to abide by the mandate, and we are going to abide by the mandate. And so we're just going to have to do our best to deal with it. And we're open to suggestions.
Thanks, Mike. There's a question from Ryan about the case management entity staff working in residential settings. Do you have questions on that, Ryan?
Me?
Ryan Pollard?
Oh yeah, sorry. I was curious on if there's any more information on what that looks like. Is it going to be up to the case management entities to kind of develop that request of it being formal, or is it going to have to be an exception request to the state saying that we have to have our service coordinators going into residential settings? Or I'm trying to review the transmittal. It's pretty lengthy, but I figured there's a little bit more work needs to be done on how agencies would receive that support from CMEs.
Yeah, good question. So that transmittal just came out, I think, yesterday evening. So it hasn't been circulating long. It may be new to many of you on the call today, but we released an informational memorandum that states when it might, like, what is allowed when a case management entity staff is going to work in a residential setting, maybe to alleviate some of these staffing pressures that provider agencies are experiencing right now and adult foster home providers are experiencing right now. So none of this requires CME staff to take this on. There are plenty of you that are just already stretched to the limit, and we absolutely recognize that. But there were questions from case management entity staff and program managers around the state asking if that was allowed, and if so, what steps need to be taken to mitigate conflicts of interest, to make sure someone is safe to provide direct support or to help out in a residential setting. So this transmittal that Ryan's discussing, it was released yesterday. I can't remember the transmittal number off the top of my head, but it just describes what that could look like if it's allowed by your case management entity, if it's something you want to do, and if a provider agency or adult foster home provider wants to hire you. So all of those things kind of have to work together for this to happen. It's not a requirement, and it's certainly case management entities or provider agencies and adult foster home providers may have their own policies in place and other restrictions that they might place on this situation happening. But it's really our intention to just make things as flexible as possible to provide more capacity and creative solutions to this staffing crisis that our system is facing right now.
Thank you.
And we do have another question in the chat. Any guidance on monitoring for site visit questions / ISP and health questions for individuals in licensed settings during COVID?
I think there's a whole section on the reopening guide on tips for monitoring things, questions that you should be asking. So definitely go there. I think even though you can't be in person, virtual with video is the next best thing. At least you can put some eyes on somebody. I think if circumstances warrant, or if it's possible, talking to the person virtually without maybe their staff present, if they might be intimidated to say what is really on their mind, is probably a worthwhile strategy to take. And yeah, just asking all of those appropriate questions, knowing the limits of not being in person. So at least ask about the things you can't see, and try to get as good of a picture of what's going on in the home as you can, given the limitations that we have. And like Caitlin was stressing before, if you have reason to suspect that a person is either being abused or facing significant health and safety risks, then mask up, do all the things you need to do, and go see the person, because we don't want bad things to happen just because of we're limiting in-person visits.
Another question, will virtual meetings be an option when the pandemic is over?
I believe we are working on that. I think it's very likely in some circumstances.
We know that it was even, I don't know, want to call it a benefit because things have been so hard. And when we had ice storms and power outages and things like that on top of COVID-19, it certainly wasn't easy. But when roads were hard to travel and people were already comfortable and familiar with using Zoom, and that was how their meeting was scheduled to happen anyway, that was a great benefit. And we know that those types of climate situations will happen again as well. So we're absolutely thinking about how can we maintain the integrity of all of our services and maximize flexibility wherever possible.
Thank you. Another question. Regarding possible Medicaid loss, many consumers who have received stimulus funds and are unable to spend in any meaningful way are exceeding the asset limits set by SSA. One provider agency sought power of attorney via ISP agreement in order to open ABLE accounts for their consumers who are not able to communicate with words. Any thoughts or guidance on that?
I mean, I can't speak particularly knowledgeably about this one. I think an ABLE account is definitely a good idea if somebody's over-resourced, and there's no reason that a provider agency couldn't help with that. I thought, though, that I saw something in the federal guidance around the stimulus that it would not impact their benefits, but don't quote me on that. I think that there is some, I know we put out written guidance on this topic. I don't have it. Maybe, Paul, if you want to send me an email, I can hunt it down and send it to you.
It may be a good time to refer someone for benefits counseling as well as
Right.
another service. Oh, Micah is saying it won't impact benefits for 1 year. So yeah, but send us an email, send Mike an email to just make sure we can verify that information. Okay, with that, it looks like we're closing in on our time with you today. And as Mike has expressed, really just tremendous gratitude for all of you for sharing your 90 minutes with us today. We know you have so much going on. We really appreciate your commitment to the people and families that you support and all of the heavy lifting that you have been doing already, and then especially over these past 19 months or so. Thank you so much.
Take care, everyone.